Good morning, everyone. Today we are going to continue our discussion on bladder cancer. We have our trainee and examiner panel. Welcome, Anish. Floor is yours.
Good morning, Mr. Shekaran. Good morning. And today we are going to discuss mostly on muscle-invasive bladder cancer. So before going into the Viva session, I have a short story to share because while preparing for the first years, I thought that we had to really know about non-muscle invasive bladder cancer, possibly a little bit about muscle invasive bladder cancer, some of the complications of surgery, and the recent advances. But I never thought that it will go into real depth. But one of my friends who had his exam just before me told me that if you're really good, the examiners will take you to the extreme and you will feel good after the examination. And fortunately for me, I prepared well for the muscle invasive bladder cancer. And the discussion was really good. And he was right. My friend was right. It went to real in-depth discussion regarding the complications, even to the extreme, like the ileal conduit complication. How do you revise the structure, the anastomotic structure in an ileal conduit, things like that. But the good thing about going to that extreme is that you will feel really good after the end of that session. So there is no limit for the muscle-invasive bladder cancer. So it is always better to prepare well. Uh, I'm saying this because during my Viva preparation sessions, when my examiners were asking about the ileal conduit, the complications, the revision rates and all, I thought, no, it's not needed for a first years. But the good thing is that if you are well, then yeah, that you can really prepare to the extreme. So this is a very important topic. Uh, is there any question before I start the Viva session?
No, thanks. Please carry on.
It's okay. Okay, thank you. So we'll start with the scenario. So you are in the MDT. You are leading the MDT because your area of interest is bladder cancer. So one of the cases that is discussed in the MDT is the TURBT of a 68-year-old gentleman, and the pathologist says that the histology shows PT1G3 TCC of the bladder with scanty muscle present, but the muscle is not involved with tumor. The surgeon who did the TURBT is present in the MDT. He says that the resection is complete visually. So what will be your suggestion in the MDT?
So given that this is a G3 PT1 with scanty muscle, in line with the NICE guidelines, I will recommend a resection in 4 to 6 weeks. Because we know that a lot of this PT1 may be upstaged, and there's also some of them demonstrating complete resection at resection.
Well done. So, do you know the evidence behind the residual disease after T1 and the upstaging that can happen after re-TURBT?
I'm sorry, I don't recall the paper.
Yeah. So there are lots of papers.
I know that upstaging can be a residual disease can be up to 40 to 50%.
Well done.
And upstaging can be up to 25%.
Well done. Yeah. So those are the numbers. And especially if there is no muscle in the first resection, then the upstaging can be up to 50%. And also, one of the other things, keywords that you can put is, you can say that the re-TURBT has shown to improve the recurrence-free survival and progression-free survival. So when you put these keywords, because this is one of the most common questions in the exam. So so we decided to do the re-TURBT. The patient agrees for re-TURBT. One of the questions in the exam is to ask, the patient is asking you, you have already done the surgery, the TURBT, why do you want to do re-TURBT? And the answer is the same regarding the upstaging residual disease.
Yeah.
So you did the re-TURBT. The re-TURBT specimen shows muscle and there is no involvement of the muscle by the tumor. So what is the current staging of the cancer?
So this would be a PT 1 TCC bladder, G3PT1 TCC.
Okay, and his staging investigations were negative. His CT scan shows that there is no size-specific lymph nodes in the pelvis or in the abdomen, and his CT thoracis is normal. Is there any size? Are you aware of the size criteria for the significant lymph nodes in pelvis?
Yes. So the size criteria is the maximum short axis diameter of less than 8 millimeter or more in the pelvis and 10 millimeters or more in the abdomen.
Perfect. Good. So as we move on, what are your options for this G3PT1 TCC bladder?
So this is a high risk superficial bladder cancer. The first option would be to offer this patient BCG therapy to prevent the risk of recurrence and progression. If this was a widespread disease, even though it's G3PT1, upfront cystectomy may also be an option.
All right. So how are you going to counsel the patient regarding the options?
So I'll see this patient with a Macmillan nurse specialist and explain that the bladder TURBT has yielded great high risk superficial bladder cancer, and this has been confirmed histologically. I'll explain to the patient that the recommendation will be to commence with BCG installation, which involves we use the LAMS regime, which involves an induction course of initially 6 courses, and then a break, and then 3 courses at 3 months, and then the maintenance course every 6 months up to a total of 27 installations.
Okay, well done. So what is BCG? What is the expansion of BCG?
So BCG stands for Bacillus calmette guerin, which is a life-attenuated tuberculosis bovis. And the way it works is that on installation, it's incorporated into the urothelium by the fibronectin receptors. And in doing this, it stirs up an immunological response locally to kill any residual bladder cancer cells.
Okay. So in your trust, which BCG strain are you using?
So we use the Oncotice strain.
Okay. And so your patient had his induction BCG 6 weeks course weekly, and you did a repeat flexible cystoscopy that was normal, no abnormalities found. He went on to have the first maintenance cycle weekly at 3 months' time for 3 cycles. Then a repeat flexible cystoscopy again shows some red erythematous raised patches in the posterior bladder wall. So you are in the flexible cystoscopy clinic, you are seeing this finding in the cystoscopy. So how are you going to proceed from here?
So I'll explain to the patient that we have this suspicious area in the bladder. It's possible that this is BCG changes, but we cannot rule out, for instance, a CIS. So I'll advise this patient that we need to perform a bladder biopsy to understand what's going on and take it further.
Well done. Will you use any adjunctives when you plan for the cystoscopy?
So photodynamic therapy can be beneficial to improve the sensitivity or the accuracy of diagnosis and yield for CIS. Narrowband imaging is the other alternative.
Okay.
that can be used.
Sure. So your patient had this photodynamic diagnosis, guided biopsy, and the histology this time shows persistence of T1 G3 tumor. So how do you are you aware of the classification of BCG failure options? Sorry, BCG failure.
So I'm aware that this will be in keeping with BCG failure, but I don't know any classification of BCG failure.
Okay, no worries. So if the repeat histology shows T1G3 persistence of high-risk non-muscle invasive bladder cancer in spite of induction BCG and one cycle of maintenance BCG, what are the treatment options for this patient?
So, given that this needs to be rediscussed in MDT, the treatment options will either be to offer this patient, consider this as a failed BCG and offer cystectomy at this point. There's also an option of re-induction and seeing if this patient responds to it.
Okay. One of the questions that can be asked in the exam is, are you aware of any recent advances for treatment options in BCG failure apart from radical cystectomy or induction, repeating the induction BCG?
Yes, there's the option of trying electromotive mitomycin, or even trying hypothermic mitomycin.
Hypothermic, yeah. So I have my notes for that, because that was one of the commonest questions that was asked during my preparation. So I had my notes, and the couple of options that are described are, as you said, EMDA, electromotive drug administration, hyperthermic installation, and there is one thing called RITE, R-I-T-E, radiofrequency-induced thermochemotherapy. And other options are intravesical gemcitabine. Even there is an option, something called as a photodynamic therapy. And one of other option is IV pembrolizumab. So I read about one of the sources, good sources for this is BJUI Knowledge. And there is a module for BCG failure options. So I would highly recommend to have a small note, only a small note of these options, because this is one of the questions that you might encounter when doing this VIVA preparation.
Yeah, thanks.
No problem. So moving forward, for this patient, he's young, he's fit and well. He had his induction BCG. Again, when you repeat your cystoscopy, it again shows persistence of T1 G3 tumor. Your MDT had a discussion, and everyone feels that because he is fit and well and he's not responding to BCG, his option should be a surgical option. Will you agree with that?
Yes, I will agree with that.
Okay. So how are you going to counsel the patient this time regarding his surgical option?
So I'll once again explain to the patient that despite reinduction BCG, that there is evidence of persistence of high-risk muscle-invasive, non-muscle invasive bladder cancer, and the recommendation will be for a cystectomy. I'll do this with a Macmillan cancer specialist nurse present. I will explain the risks, benefits, and alternatives of a radical cystectomy. I will use a BIOS consent form to guide me in this. Particularly, I'll explain the risk. This is major surgery, risk of infection, risk of bleeding, risk associated with bowel resection and anastomosis, such as anastomotic leak. I would also anastomosis of the ureters to the conduits, such as strictures or urine leak. I would explain also the risks of anesthetic risks, such as heart attack, DVT, PE, and even the risk of mortality associated with this surgery. And with the patient's consent, I'll get them to sign a consent form and hopefully plan for proceeding with surgery.
Well done. So I'm taking you to a different scenario. In the MDT, there is another TURBT, and this time it evidently shows that the muscle is involved. And the pathologist says that the current staging is PT2, G3, transitional cell carcinoma of the bladder. So the MDT decision is to discuss the option of radical cystectomy with the patient. So when you counsel the patient about radical cystectomy, how will you tell him about the approaches for radical cystectomy?
So I'll explain to this patient that radical cystectomy can be done open. It could also be done minimally invasive, i.e. laparoscopic or robotically.
Okay.
I'll explain that the purpose of both approaches are the same, which is to remove the bladder and to divert urine. I will also explain a bit more in details about the types of urinary diversion, which could be an ileoconduit, or it could also be an orthotopic new bladder if this patient is young and fit. There's also the continence cutaneous diversions options as well. And having explained all this to the patients, I will then be guided by their decision.
Okay. Is there any advantage of doing robotic compared to open surgery? Are you aware of any evidence comparing these two methods?
So there was the Bolero trial that didn't actually recruit enough, I think. And so because of the low numbers, there was no statistical inferences to be drawn. But I don't think there's a new study published in this year, actually, it's called Race Trial. And it's a Belgium paper, more of a comparative study between open and robotic, and there was no statistical difference between the complications or the health related quality of life. Was the conclusion of the paper.
Well done. So a couple of keywords I'll put when they ask about the RACEL trial is one word is non-inferior. So the robotic was non-inferior to open, and the trial was for 2 years, and the progression-free survival, as you said, the survival, adverse events, quality of life were not different between these two approaches.
Yeah.
Exactly. So will you counsel the patient regarding the lymphadenectomy?
So this is, yes, I will. This is part of the radical cystectomy to perform a pelvic lymph node dissection, which helps as well in the complete staging, pathological staging of bladder cancer. I'll explain that there are inherent risks with this, risk of damage to major vessels, also risk of pelvic collections or lymphocytes. Yeah.
Well done. So one of the things that I'm suggesting there is when during my preparation, I was told that whenever this is a standard question, T2 tumor, and the question will be how will you counsel the patient? And we can always say that I will counsel the patient regarding the radical cystectomy, lymphadenectomy, and urinary diversion, like in a single word.
Yeah.
So that will avoid a lot of questions coming back from the examiner. Yeah. So what type of lymph node dissections are you aware of for accompanying a radical cystectomy?
So I think you have the standard and the extended lymph node dissection. The standard dissection will involve dissection of the external iliac, internal obturator, presacral, and common iliac. But the extended may actually go up to the bifurcation of the aorta.
All right. What about super extended lymph node dissection?
So that will probably go up to the aorta itself and to the inferior mesenteric branch.
Yeah. So standard is up to common iliac, extended is up to aortic bifurcation, and super extended is up to inferior mesenteric. Are you aware of the end staging in the TNM classification?
Yes. So the TNM 2017 end stage is N1 is single lymph node in the true pelvis, N2 multiple lymph nodes in the true pelvis, and N3 is lymph node in the common iliac.
Okay. And what are the accepted boundaries for a standard lymph node dissection?
So the lateral boundary will be the genital femoral nerve. So external iliac, genital femoral nerve, lateral boundary. The obturator group of lymph nodes. Medial boundary will be the wall of the bladder, involving the internal hypogastric group of lymph nodes. Inferior boundary will be the Cloquet's lymph nodes, and the superior boundary will be the common iliac.
All right, well done. And coming to the radical cystectomy, for men, what are the structures that you remove during a radical cystectomy?
So the bladder, the prostate, the distal ureters on both sides, the lymph nodes, pelvic lymph nodes, in line with lymphadenectomy, will be removed.
Okay, and the seminal vesicles as well. And this is one of the commonest questions that is asked, and it's always better to say it when you are having a T2 tumor, but always the examiner will come back to you. Like they will ask about the role for, will you suggest the option of a neoadjuvant chemotherapy in the MDT if you are having a T2 tumor?
Yes, the current recommendation by NICE is to offer neoadjuvant therapy, cisplatin based, in where there's evidence of muscle-invasive bladder cancer, and this is because it offers a 5-year survival benefits of about 5%, and reduces mortality as well, 15% reduction in mortality.
All right. Where does that evidence comes from?
That's the meta-analysis, the advanced bladder cancer meta-analysis.
Okay. And the next question was one of the questions that I had during my preparation. So the examiner asked me, are there any new evidence for neoadjuvant chemotherapy? Because the ABC meta-analysis was in 2005. So he asked me whether there are any new evidence for neoadjuvant chemotherapy. Are you aware of any new evidence?
No, I'm not.
Yeah, at that time I was also not aware. So then when I went back, there is a meta-analysis. There's a systematic review, and it was something called a two-step meta-analysis. The author was Yin, Y-I-N, and it was published in 2016. And that was the one that said that the absolute improvement in survival at 5 years is 8%.
Okay.
And the number need to treat was 12.5 in that analysis. So sometimes if you say ABC, this question can pop up. What's the new evidence for the neoadjuvant chemotherapy? That's why in some papers it said that the absolute improvement is 5 to 8%. That 8% comes from this study.
Yeah, thank you.
are you aware of any role for neoadjuvant immunotherapy?
I'm not familiar with that.
Yeah, I mean, it is still in trials. There is no proven trials which says that there is an advantage for neoadjuvant immunotherapy, but the trials are going on with the PD-1 inhibitor pembrolizumab.
Yeah.
And coming back to the neoadjuvant chemotherapy, you said that there is a 5 to 8% absolute improvement in the survival. Can you tell me one of the regimes that are commonly used?
So it could be either a combination of cisplatin and gemcitabine, or MVAC.
Okay.
Given in the neoadjuvant setting.
All right. What's the advantage of giving neoadjuvant chemotherapy apart from the evidence of survival?
So it could downstage the tumor as well, and make resection slightly easier.
All right.
It may also reduce positive margins.
All right.
In downstaging the tumor.
All right. Good. I'll add two more things because it will help us to be aware of the chemosensitivity of the tumor. And the patient will be more compliant and tolerable to chemotherapy if it is before cystectomy.
Okay.
And what are the downsides of having a neoadjuvant chemotherapy?
So there's a potential risk of delay in radical cystectomy if this is a chemo non-sensitive tumor.
Yeah, exactly. Well done.
Yeah. And also it may reduce the performance status of the patients following chemotherapy.
All right. Coming to the urinary diversion, what type of urinary diversion are you aware of?
So I'm aware of the ileal conduits. I'm also aware of cutaneous continent diversion, such as the mains 1 and Indiana pouch, and also orthotopic neobladder, such as the Studer neobladder.
All right. Okay. One of my suggestions, because I took that from the EAU guidelines, because EAU guidelines says that the urinary diversions can be abdominal diversion, orthotopic diversion, and uretrosigmoidostomy. I was not aware that this type, for the exams, when you give a systematic classification, it creates an impression on the examiner. Okay. It was not given anywhere else, but when I went to the EAU guidelines, these 3 classifications were there. So once when the examiner asked me about this question, these were all mock vivas, not the original exam, but for the mock viva. When he asked, I was just fresh on reading the EAU guidelines, so it was fresh on me. So I just said that the classification can be abdominal, urethral diversion, and uretrosigmoidostomy. And he was very happy on hearing that classification. And he said to stick on to that approach. Whenever there's a classification or whenever there's a systematic approach, give that to the examiner and they will be happy.
Okay.
So ileal conduit. Coming to the ileal conduit, can you tell me about some of the complications that you can expect with an ileal conduit?
So there are complications associated with bowel resection and anastomosis, such as anastomotic leak, ischemic bowel, but also complications associated with the ileal conduit itself. So there could be urethral ileal strictures or stenosis, and with regards to the conduits around conduit to skin, you could have conduit stomastenosis, parastomal hernia, prolapse, and these are the potential complications. There's also complications of leak, pelvic selections due to leak around the anastomotic site.
All right. I will just put some numbers into that as well, because it is given in EAU, because that numbers were easy to remember in the sense that it was 48 and 24. For some reason, it is just half of the other number. So the 48 was like the when you explain in the exam, you can say that there are early complications, which is around 48%. So the patient can expect that there is at least 50% complications in the early postoperative period. And the long-term complications can be up to 24%, including the deterioration of upper tracts.
Okay.
So you said to me about the urethral diversion or orthotopic neobladder. Are you aware of any specific type of orthotopic neobladder?
So I'm aware of the study orthotopic neobladder, which involves isolating a 60 centimeter segment of the distal ileum, 20 centimeters from the ileocecal valve, and creating, detuberizing this segment of bowel to create an orthotopic neobladder. A sleeve of the proximal bowel will then be used for anastomosis of the ureters to this neobladder.
All right. What are the contraindications for a neobladder?
So absolute contraindication would be extensive bladder neck tumor or CIS. Relative contraindications would be things like low EGFR below 50, previous bowel resection, pelvic radiotherapy, or hydronephrosis.
Okay. I will add the hepatic impairment, and just like you said, any bowel problems like short bowel syndrome or inflammatory bowel disorders. And yes, like you said, the patient who is unwilling to perform CIS, that's also a contraindication.
Yeah.
If the pathology, what's the concept of neobladder if there is lymph node involvement in CT scan? Can we go ahead with the neobladder, or is it a contraindication for neobladder?
I'm not really sure, but I will presume that if this lymph node is amenable to lymph node dissection, then it shouldn't be a contraindication. I'm only guessing.
Exactly. So one of the things is if it is only minimal, like N1 involvement only, then we can go ahead with the orthotopic neobladder. But for N2 and N3, possibly because it might need a adjuvant radiotherapy afterwards, this is considered to be a contraindication for orthotopic neobladder. So are you aware, for a radical cystectomy, one of the common questions is, are you aware about the enhanced recovery after surgery protocol?
Yes, so this is a protocol that's come into place to improve the immediate post-op recovery and outcomes following radical cystectomy. It involves the preoperative and also immediate post-op period, and the key is to feed this patient as soon as possible and mobilize the patient as soon as possible to improve or minimize complications such as DVT, but also improve healing and recovery process.
Okay. Are you aware of the CPEX testing?
So CPEX, cardiopulmonary exercise testing, is a test which is used by the anesthetist to decide if the patient may be fit for major surgery and exclude those that may not be fit for it. And it involves getting the patient to exercise, maybe on a cycling bike, and taking some parameters to decide, for instance, the anaerobic threshold, and if this patient will be suitable for major surgery.
All right, well done. So coming to the follow-up after radical cystectomy, what type of follow-up do you do for a radical cystectomy patient?
So follow-up of this patient will involve the radiological follow-up to assess for any recurrence, and also if we haven't done a urethrectomy, to also follow up the with surveillance to look for any recurrence. So I will usually I'll follow up these patients up with a CT scan at 6 months, 12 months, and 24 months, and then upper tract imaging yearly afterwards. With each visit, it's advisable to check this patient's using his B12 and folate as well, and bicarb levels, and also in terms of urethral surveillance, you could either do urethral washouts and or urethroskopy to look for any evidence of recurrence.
Okay. And the NICE guideline says to do the urethral washinocytology for 5 years, isn't it?
Okay.
Yeah, it will be nice to bring that number. But it was perfect. What you said was perfect. That's the way to put it. What's the role of radiotherapy in muscle-invasive bladder cancer?
So radiotherapy is the alternative treatment for muscle-invasive bladder cancer judged at clinical equipoise with cystectomy. And this is usually done by our oncology colleagues.
Okay. Comparing radical cystectomy and radiotherapy, is it better than radical cystectomy, or is it worse than radical cystectomy?
So I don't think there's a strong evidence to say that one is better than the other. There was the SPARE trial, which was going to compare both, but did not recruit enough, so couldn't draw any statistical conclusions. However, there is some suggestion to say that the cystectomy may be slightly better in terms of overall mortality, but there's no strong evidence to go by comparing both.
All right, well done. Are you aware of trimodality therapy?
Not exactly sure what that means, trimodality.
Yeah, so trimodality therapy is used mainly as two purposes. One, if it is a small T2 single lesion without any evidence of CIS, and if you can do a complete TURBT, so in patients who are fit for cystectomy but they want to preserve the bladder function, the trimodality therapy involves doing a maximal TURBT and giving the chemoradiation, so chemotherapy and radiotherapy. So that is a trimodality therapy. And the radiotherapy, for the chemotherapy, we use radiosensitized or radiosensitizers like chemotherapy. It is also used in patients who are not fit for surgery. So these are the two indications where we can do trimodality therapy. It involves, there's a couple of protocols that we follow for trimodality therapy. It's not the best option, but that's one of the questions that can be asked, trimodality therapy. So basically it is a combination of surgery, chemo, and radiation together. Are you aware of any molecular subtypes of muscle-invasive bladder cancer?
So you could have the classical TCC or other variants like nested variants or small cell cancer. Okay.
So those are the variants histology. So I'm saying all this because this might not come in the exam, but if you're doing really good, these are the questions that can be asked. So there is two main group of molecular subtype, and these are commonly said during the presentation. So you can say that it is luminal and then basal squamous, and possibly that is the only thing that we need to know. And there are different subtypes based on that. But if you say luminal and basal, and that's two major molecular subtypes. Coming to the complications, post-op complications, how do you classify post-op complications?
So generally speaking, you could be classified as immediate complications and delayed complications.
Mhm.
So with regards to
Is there any?
cystectomy,
Sorry, I think I was not clear about the question. Is there any objective classification for the postoperative complications?
yes, there is.
Sorry, I'll be direct.
I'm trying to remember. Yeah,
Are you
I
aware
know.
of the Clavian-Dindo classification?
Yeah, exactly. That's it. The Clavian-Dindo classification. Yes. So Clavian-Dindo classification classifies objectively post-op complications. So it's Clavian-Dindo 1 to 4. Clavian-Dindo 1 is complications not requiring anything more than an analgesia or intervention. Clavian-Dindo 2 would involve things like antibiotics or even blood transfusion. Clavian-Dindo 3 could be into A or B. 3A is where there is intervention with no general anesthetic, and 3B is where there's intervention with general anesthetic.
Well done.
And Clavian-Dindo 4 will be ITU escalation, I believe.
Exactly. So 4 is again divided into 4A and 4B, where 4A is single organ dysfunction and 4B is multi-organ dysfunction.
Yeah.
But well done. So we'll just touch upon the metastatic bladder cancer. If in an MDT, if the discussion comes for a patient with metastatic bladder cancer, are you aware of the protocol that we usually follow, the medications or the chemotherapy or immunotherapy that we usually give?
So I believe that this will depend on the patient's performance status and kidney function.
Well
so the first line will be cisplatin-based chemotherapy. So cisplatin plus gemcitabine or the MVAC, which is methotrexate, vinblastine, doxorubicin, and cisplatin.
All right.
And so this would be the two regimens for chemotherapy.
All right. And what happens if the patient is not eligible for platinum?
So if they're not eligible for cisplatin, you could consider carboplatin in combination with gemcitabine or I think carboplatin and gemcitabine.
Okay, all right. And what about the immunotherapy?
So I'm not very familiar. I need to revise with the immunotherapy. But you did sort of mention that earlier on.
Exactly. Just put two keywords there. That immunotherapy is an option for platinum ineligible patients. We'll do the staining for PD-L1, and if it is PD-L1 positive, then the outcome of immunotherapy is better. You might not need to say the immunotherapy agents, but most commonly used ones are pembrolizumab and atezolizumab, even though there are some acquiring problems, funding problems with pembrolizumab with the NICE. Yeah. And if it is PD-L1 negative, then it will go for either supportive care or still going for the immunotherapy. Just to be aware of some couple of keywords if that question comes to cover that. Very unlikely that a metastatic bladder cancer will be asked, but just to cover your base.
Okay, thank you.
And one more thing before concluding, are you aware of any new advances in local staging of bladder cancer? I'm asking about the MRI scan.
So MRI, I think the NICE recommends either MRI or CT. If there's some uncertainty with the scan, then a PET scan can be done. So this is what I recall about any advances.
Okay. Have you heard about VIRAD scoring, like PIRADS in prostate?
Yeah. So VIRADS, scoring VIRADS 1 to 5 is a scoring system similar to PIRADS for bladder cancer. It's gaining popularity, but It's not yet fully. It's not widespread in widespread use yet.
Exactly. Well done. And I always say that it's just similar to the MRI in the prostate. There is T2 weighted imaging, there is diffusion weighted imaging, and there is ADC mapping as well. So a couple of keywords on that one. And if you talk about for like 40 seconds on that one, Robert. Well done. And just regarding the enhanced recovery after surgery, I mean, it was always difficult for me to put it in words when this question is asked. So what I did was to make a small note on how to explain ERAS, and that is my standard answer whenever this question was asked. So I'll put that in the group. In the YouTube, in the comment section, my notes on the enhanced recovery after surgery, because when this question is asked, we had to give a clear definition of what is ERAS. So it's mostly what I made the notes was like, so ERAS is a multimodal, multidisciplinary approach of a series of perioperative programs for enhanced recovery and decrease the length of stay in the hospital, but without increasing the complications.
Okay.
So if you say something like that, then they know that the examiners know that you know about the ERAS.
Yeah, it's always difficult to put these things in, a good summary if you haven't actually made notes. So yeah, your notes will be helpful if you can.
Yeah, because if you put the keywords, then that will, it will give us enough time to proceed further as well.
Yeah, thanks.
Thanks. So, I think we have covered almost a good part of the muscle-invasive bladder cancer part. Mr. Dhanasekaran, are you?
Yeah, that's a very good, very detailed discussion. Anish, the only thing I want to slightly change is whenever a trainee like Emika is not presenting an answer, I wish you to finish it off. Say, for example, the various types of BCG failures and those things.
Okay, all right.
So that it becomes like a complete single source for the other trainees. Do you want to complete that one, because we haven't completed?
Yeah. So I will take that.
And when you're doing that, Emika, again, a very nice presentation. Obviously, this is a kind of higher end discussion on the bladder cancer. So there is always a lacunae on few things, like, for example, enhanced recovery protocol or various methods of neobladder reconstruction. What is the challenge in the reconstruction when you compare to men and women? What is the specific challenge? So there will be always some questions on that. For example, PDL1 is now something like a talk of the town, and immunotherapies have become so common. There is a good possibility even the immunotherapies will be given upfront compared to chemotherapy, because it ticks the box of less side effects and better immune controlled things. So I wish you to spend some time not only for bladder cancer, even for kidney cancers, on immunotherapy, because that topic is now very much coming across. And this is a subject or table where getting 6 or 7 is quite easy, but if you are able to touch the little bit parallel topics, like, for example, Clavintinto classification and this CPEX testing and enhanced recovery protocol, and what is the difference in the outcome between the radical cystectomy, robotic assisted and open. So the main outcomes, if you see from the studies, it's mainly like less intraoperative time, maybe sometime based upon the surgeon, and less in-hospital stay and less hemoglobin loss. But oncological outcomes were same. That's what we need to stress on the exam.
Okay.
Okay, Anish?
Thanks.
And a couple of things that we have to touch upon on this one is like the other variants. Also, the squamous cell cancer, schistosomiasis is one of the stations. So we will do it as we move on. Okay. And regarding the BCG failure, I prepared all my notes based on the BJVY knowledge, as I said before. So the classification is called the International Bladder Cancer Group BCG failure definitions. And basically there are 4 definitions. One is a BCG refractory when there is always a failure to achieve a disease-free state. And the other one is BCG resistant, which was our case today, which is the recurrence or persistence after the induction course. And BCG relapse is when they have achieved a disease-free state, but then it relapses afterwards.
Yeah.
And BCG intolerant, even though it cannot be considered as failure, is the term BCG intolerant if the patient cannot tolerate.
Yeah.
So the keywords are International Bladder Cancer Group, refractory, resistant, relapse, and intolerant.
Intolerant. Yeah. Thank you.
And the other, we have to always say about the other options like BCG failure apart from radical cystectomy, like the electromotive drug administration, RITE, or we can say that radiofrequency induced thermochemotherapy, intravesical gemcitabine, photodynamic therapy, and even recently not recently, almost 1 year now, FDA approved pembrolizumab.
Okay.
Yeah, I think that's about the BCG failure.
Good, very good.
Thank you.
Now, what is the next steps, Emika, is now we have touched upon so many things. You may have taken note on few things which you may have to work on, because CPEX can be asked quite in detail in the technology table. So either way, you need to know one way or another. So my view is you will be given the opportunity to present this muscle-invasive bladder cancer at least 3 times with our group itself before going to the exam. Leave alone the Viva practice you are going with BOWS or our West Midlands Viva Day on October 25th. If you include that, I'm sure you will present this at least 5 times. And every time your aim is to make it more full of values and the knowledge, but using less sentences. So that you will take less time, because the time is very precious. You need to really condense your material into the 10 minutes. That's the main part of the training. Okay?
Yeah. Thanks.
Good. Anish, you want to add anything before completion?
Yeah, regarding the cardiopulmonary exercise test, I mean, Emika has had all the keywords in that one. Only addition for that would be to have the numbers on hand, because when you do the cardiopulmonary exercise testing, what we are looking for is the VCO2. And yes, you said about the anaerobic threshold, the exercise capacity. So when the numbers comes, if it is more than 11, it is good. And if it is from 8 to 11, that means that the patient will need a HDU support. And if it is less than 8, it is very high risk. And if it is, if possible, consider the non-surgical options.
Yeah.
So that's the only addition that I have to add for the CPET testing.
Thank you.
Okay, thank you very much. Now you know the numbers with CPACs also, because the only way you will remember this is not by reading, not by writing. Of course, notes is very important, but you need to bring it out in this Viva training days, so that it will come automatically during the exam. And the examiner should feel that, okay, this 10 minutes, this guy is able to fill up with so much of knowledge, and there is no major lacunae, and there is nothing wrong in saying no. Say, for example, in the exam, suddenly the different types of BCG failures may not click in your mind, and you can say, I don't know. Nothing wrong in it. It will never affect the result. In fact, it will always give a good result also, because you will save a lot of time, and you will go ahead with much more difficult questions, and examiner will forget that you said you don't know for one of the question. And at any time, never guess or never say an answer which is approximate to correct one, which may end up in a wrong answer. Wrong answers will create a kind of a red flag in the examiner's mind. All your answers should be correct, and if you don't know, you don't know, so that you can have time for answering more complex answers, and make sure the examiner forgets that you said you don't know for at least one question. Okay?
Okay. Thank you.
Good. As you said, we will continue with you on Friday if it's comfortable for you, and we will do prostate cancer with you. Thank you for your time, Emika and Anish. I'm sure this will be a very good source for our other trainees. Anish, I'm thankful for adding your precious notes in the comment section of the YouTube. And Emika, you also please feel free to ask any questions, and use us. We both, not only we both, we have at least 4 or 5 examiners, you know them. We are all serving as a good resource. It's up to you to get the best out of us. If you prepare to a very best level, we will try to prepare ourselves to see can we take you one step higher than what you are. So
Yeah.
you can even use us as one of the lazy source. So if you have a question but you feel no time to get into the search and get the articles, just post it in the comment section. We are happy to help you
Okay.
with that.
Thank you very much. Thank you.
Okay. Have a good day, rest of you.
Thanks
You
so
too.
much.
Yeah.
You too.
Bye.
Thank you. Bye-bye.
Bye-bye.
Bye.